To our first of two lectures on anxiety disorders. Today we're going to be talking about specific phobia, panic, agoraphobia, and social anxiety disorder. Always love these cartoons. And for the rest of his life, the young reptile suffered deep emotional scars. I'm sure if we all think back to our phobias or the fears that we have, they might not be diagnosable, but they all generally have some origins in childhood. I remember I'm not super comfortable around dogs, and I remember as a young child getting bitten by one, and just that uncontrollability of the situation has led me to that fear. So oftentimes with many of these fears, there's some historical development in terms of having them. So one of the key differentiations we need to make is anxiety versus fear. So, anxiety is really the apprehension of an anticipated problem. It's not really that you are encountering it. It's kind of this nebulous, more kind of fear of something happening in the future. Whereas fear is an appropriate response to an immediate danger. So, if you are standing at the edge of a cliff, you are feeling fear because you may fall off. But worrying about whether you are going to be able to get a job with your degree when you finish, that would be anxiety. Both of those involve physiological arousal. So your body is reacting, they're sending the fight or flight responses, your cortisol levels are increased. With anxiety, you have moderate levels of arousal. With fear, you have higher because it really has to get your body into gear, and you have that adrenaline that's being shot out so that you can react appropriately. You've probably heard about those stories where, mothers throw cars off their children, and that's the adrenaline that comes with being fearful. Both can be adaptive because they trigger the fight or flight and they may save lives, as I mentioned. But while anxiety can be good because it increases preparedness, for example, if you have no fear about failing, you're not going to care whether you're not going to care enough to prepare for your exam, but you're going to care if you do care about failing, then you're going to prepare and get your act together. So then you need a moderate level of anxiety to work. So let's kind of, by a show of hands at home on your computers, who's afraid of small insects? My kids are. Animals, we all have some animals that we're probably more comfortable around than others. I can imagine many of the zoo animals we're probably all afraid of. Reptiles. Can't say that I love snakes, even though some of them are harmless. I remember swimming at my cottage in the water snakes, swimming around me, and I just hated that. Speaking to large audiences was something that I used to be afraid of. Not so much anymore. I did kind of exposure therapy through my graduate education, and now I feel quite comfortable. Some people feel uncomfortable speaking in front of small groups of familiar people, meeting new people, and attending social gatherings. So there are three components to anxiety. There's the physical component, so you have the physiological arousal, the cognitive component, which is your thoughts, and then there's the behavioral component in terms of what you do. So our physiological system is when we have a perceived danger or stressor, our brain sends a message to our autonomic nervous system, which is our sympathetic nervous system, or the fight or flight is activated, which is kind of an all or none. Like once that's activated, then those hormones are being released. And so it also sends messages to the pituitary gland, which then has a slower endocrine response. So we have both the autonomic and the endocrine response that are happening. And so a bunch of hormones are released. Adrenaline, like we talked about before, and noradrenaline. Those are released from the adrenal glands on the kidneys. We also get the cortisol. So these are chemicals that are messengers to continue activity. So that's the arousal. So that kind of keeps us working. It's kind of like the same buzz in a way that you get from caffeine, except that in intensely feared situations, that's much higher and much more quick. The parasympathetic nervous system is built in to counteract the mechanisms of the sympathetic nervous system, and it restores the calm feeling once the danger has eclipsed. However, this then doesn't work as well with anxiety when there seems to be kind of an ongoing stressor, and then it's harder for your body to return to that homeostatic level. So adrenaline, noradrenaline, cortisol take a while to destroy. So that's kind of, if you've ever been in one of those like feared situations, you notice that even after the fear has subsided, your body is still feeling those things, and you still feel like kind of this very strange sensation. Those are kind of still the hormones in your body that are being there. You'll also notice that your heart rate speeds up so that your blood is now flowing throughout your body more, and it's redirected from places that it's not needed, from like your skin, fingers, and toes to places where it's more needed, like your large muscle groups, thighs, and biceps, because oftentimes it requires you to run quickly or be strong. You'll also see increased respiration, so increased speed in breathing or deep breathing. So so after you'll sense your heart racing and you'll feel like you've just run a race. You'll see increased sweating because your sweat glands are affected. And so this is all kind of preparing your body for that fight or flight response that you may need in these extreme dangerous situations. And these are your behavioral responses. So when we don't actually have to attack or run, which is the case maybe in some anxiety situations, are these behaviors need to go somewhere. And so you'll see people kind of when they're feeling anxious, tapping their foot, pacing, or snapping at other people because it has to be redirected other places. In terms of our cognitive system, you'll often find that when you're anxious or afraid, it's hard to focus. Like when you're afraid of something, people very much focus on that feared situation, and so you kind of search for that situation, and you're hyper focused on that. You can't concentrate as much on daily tasks, and anxious people complain that they're easily distracted from daily chores and have trouble with memory, and that's because they're not encoding information as well, because they have a hard time focusing on things other than the anxiety or the fear related stimulus. So this is kind of the U-shaped function of anxiety that I mentioned earlier. Sorry that it's a little bit unclear here, but basically you see that there's a inverse U with the peak in the middle kind of showing the optimal level of arousal. Like if you don't have enough anxiety, you don't do anything. You're kind of like one of those lazy bumps on a log. A little bit of anxiety is good because it then or a moderate amount allows you to get stuff done. We need a little bit of that push. Too much anxiety, and then you are kind of overwhelmed. I know this happens to me a lot. For example, you know, um, when a little bit of stress is good, it gets me going, it gets me motivated, keeps me active. But when I feel like I overwhelmed, when I have too, like when my every other email that comes in is something with some attachment that I have to reread or do something about or look over or make edits to. And by the end of the day, I have like 10 or 15 of those. Then my anxiety level gets too high and I feel almost paralyzed. And so that's kind of where I am at the top of the grid. That's why I like to keep my email box empty. I'm big on that. So anxiety disorders are highly prevalent in our society. So you'll see um, that in terms of lifetime prevalence of any diagnosable anxiety disorders, 40% of women will report them, 26% of men, with a total of a third of us in the course of our lives will have some sort of diagnosable anxiety disorder, and a 12-month prevalence, meaning that at any 12 months, is that um, that about 21% of people will have an anxiety disorder. So given some background and history, in the early 1800s and 1900s, like we talked about last lecture, we had Freud with the psychoanalytic perspective, and he talked a lot about neuroses, which were largely anxiety-based. These kind of, it was mostly generalized anxiety disorders as opposed to kind of more specific fears, if you kind of conceptualize them in today's terms. But then in the 1920s, we have Watson, who did classical conditioning on poor little Albert and caused him to fear little bunny rabbits, and showed how phobias develop. And then in the 1960s, Hans Eysenck talked about neuroticism kind of as a basic personality dimension, like as part of like the neo-PI, where he described neuroticism with strong emotions, being moody, restless, and anxious. There's a lot of comorbidity in anxiety disorders. So, for example, half of people with one anxiety disorder meet criteria for another disorder, which then suggests to us that there might be something going on here that that there's not a lot of distinction between them because it doesn't necessarily make sense. Like maybe these are all one grander thing, or we talked about some of the reliability and validity with some of these symptoms, and so maybe that's something what's going on. We also have people who have subthreshold symptoms, so they don't meet the full diagnostic criteria, but they do have enough impairment in functioning that it's causing them problems. And so you could receive therapy for something, but you don't necessarily meet the diagnostic criteria. About three-fourths of individuals with an anxiety disorder also meet criteria for some sort of other disorder, non-anxiety based, with 60% meeting criteria for major depression. You see a high comorbidity between the two disorders. And then a lot of others meet criteria for substance abuse use disorders or other personality disorders. A lot of people with anxiety will self-medicate with alcohol or drugs to decrease their anxiety. Women are twice as likely as men to have an anxiety disorder, specifically panic, generalized anxiety disorder, and specific phobias. But things like agoraphobia and social anxiety disorder, while females are still higher than males, it's not a 2-to-1 ratio, it's slightly less. There are some biological explanations for this, might be hormone related. You'll see peaks in anxiety around certain periods in life where women's hormones vacillate. They're not sure if that's true or not. They're still investigating. There's also like women like to have more control over situations in some cases. There's a socialization behind it. And also there's in our society, women tend to be more likely to report symptoms, where like women can talk about feeling anxious, men are told to hide their feelings, and so while men may be suffering, they may be suffering in silence. Again, these are all potential explanations. They're not necessarily the actual causes, so a lot of this stuff still needs to be further investigated. There's also, as we talked about in lecture one, cultural factors that can influence the presentation of anxiety, as the focus of anxiety can vary in different cultures. For example, in Japan, there is Taijin Kyofusho, which is their equivalent of social anxiety disorder. It's like our social anxiety disorder, but it's really a fear of offending or embarrassing other people and not ourselves. So in Western social anxiety disorder, it's really a fear of embarrassing ourselves. But according to this construct in Japan, it's a fear of offending or embarrassing other people. And so it's important to understand these distinctions, especially when evaluating people from different cultures. So cultural influences can influence what we come to fear. For example, people who live in Africa among many, reptiles and bugs may have less fear of them than we do. How likely we are to report. So there's been some research that in some Asian countries, people tend to underreport anxiety even though they're experiencing it. And also what's considered normal. I mean, in social circles, some, some people feel like it's more likely to report and other people feel it's less likely to report just based on what is normal around you. In terms of risk factors for anxiety disorders, there are genetic factors that in twin studies where they have twins and they look at their concordance for these things. Ideally, twins separated at birth where they're raised in different environments but have the same genetics. But they found a 20 to 40% concordance rate for phobias and GAD and 48% for panic disorder. Especially there, it should suggest there's some biological basis to the development of panic disorder. When you compare twins who share the same genetic material to siblings who share who do not have the same genetic material, it's when you can kind of tease some of those genetic factors apart. There are also neurobiological factors such as overactive fear circuits with the amygdala, and we also see low levels of serotonin and GABA and higher levels of norepinephrine or noradrenaline among those who have anxiety disorders. There are also personality factors that are related to the development of anxiety disorders. For example, we'll see behavioral inhibition from early age. So children who go on to develop anxiety disorders might be more agitated and cry in novel settings, and you can see that in children as young as 4 months. And they found that Those types of behavioral inhibition predicted symptoms of anxiety in childhood and social anxiety in adolescence. Here we see the construct of neuroticism again, kind of as Eysenck describes it. And you see those individuals who are higher on this construct, they tend to experience and react to events with greater than negative affect. So that's kind of like the individual differences. You can have the same event and people react to that very differently. Thus, people with higher levels of neuroticism might have more extreme reactions. And high levels of neuroticism are linked to both anxiety and depression. So these are probably innate personality characteristics that predispose people to experience some of these symptoms. In terms of cognitive risk factors, we have perceived control. People who believe that they have little control are more vulnerable to anxiety disorders. And you see this in people who have a history of childhood trauma or punitive parenting. If you kind of think about, you know, the learned helplessness theory of Seligman, where the dog eventually learns that no matter what it does, it's going to get shocked and it kind of gives up. And so those people might have less sense of internal locus of control and therefore may be more vulnerable to developing anxiety disorders. And people who have high attention to threat. You see people who are constantly more vigilant and they tend to notice negative environmental cues more. There's some potentially automatic processing of these events, and therefore they are more primed or prone to see these, and they're be more sensitive to them than some of the others. Other risk factors, such as there are social ones. So people who have more negative life events, so if you have like bang, 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 negative thing after negative thing, it can really precipitate anxiety for, you'll see things like loss of a job, end of a relationship. And they found that 80% of people who are diagnosed with panic report experiencing a severe stressor right before the onset of the disorder. So loss of a job, it's kind of this feeling of overwhelming hopelessness and just not knowing or fear. So you can see that. In terms of treatments for anxiety disorders, they generally tend to be behaviorally based. We see a lot of exposure therapies. If you take my psychotherapy class, you'll learn more about how those are implemented. But the theory behind it is that we have a tendency to avoid, though it's like the Mauer's two-factor theory, we have a tendency to avoid things that make us afraid or uncomfortable, but by avoiding them, we reinforce that avoidance. And therefore, every time we come in contact with those things, it produces intense anxiety and more anxiety that's warranted. So that the way to overcome that is through exposure. If you ever saw the show Fear Factor, you put like people in like a tank of spiders. That would be called implosion therapy or flooding, where you kind of do it all at once. Or you could have systematic desensitization, where you gradually expose somebody to their feared stimulus such that, eventually they can kind of get to that 10 on their 1 to 10 hierarchy. You can also do cognitive therapy, where you challenge people's personal beliefs about the negative outcome of things. So like, why are you afraid of that tiny little spider? It's not poisonous. What can it really do to you? And then you can do that. I ideally like to do kind of both. The behaviorally based treatments for anxiety disorders seem to have the best results, but I think that in terms of understanding and preventing them from reoccurring, I think the cognitive component and the cognitive restructuring and giving people a sense of empowerment is especially important. People also take anxiolytics. You hear people taking Xanax and things of the like, Klonopin, for anxiety disorders, but you want to make sure that people don't rely on these, because while they can help in this situation, they're not a long-term, solution. That means that people don't learn how to deal and cope with these things, on their own. And if you look at the research definitely shows that these behavior therapies do work with anxiety disorders and can be very effective. And so while your patient may be taking some of these medications to help them cope during very difficult circumstances, ideally, eventually you can wean them off these medications so they have a sense of self-efficacy. So you see that the two most common types are benzodiazepines. Also, you'll have benzo, so that's Xanax and Ativan, as well as you'll see prescriptions for antidepressants like Prozac, and the like. So, but there are side effects, and they can have withdrawal symptoms. And you'll see now that people are overdosing and dying based on these medications if they're taken in too high doses or in combination with other medications or with other drugs. So it's very dangerous, and we often see relapse in the symptoms of anxiety once a medication is discontinued. So the DSM-5 anxiety disorders include separation anxiety disorder with the onset before 18, selective mutism with the onset generally before age 5, and what we're going to be talking about today, specific phobia, social anxiety disorder, panic disorder, um, and agoraphobia, which is now separate from panic disorder. It was together with panic disorder in DSM-4, and then generalized anxiety disorder. So first we'll start with specific phobia. A specific phobia is a marked and persistent fear of an object or situation which is irrational and unreasonable. It produces an anxiety response every time you come in contact with it, which can also be panic, a panic attack, and or the object or situation is endured or avoided. It's avoided or it's endured with this extreme distress, so that you're extremely distressed whenever you're in that situation. In terms of differential diagnosis, so how do you separate an anxiety disorder from other, or a specific phobia from other types of disorders? Um, it's not separation anxiety disorder because it's not related to the fear of separation. It's not social anxiety disorder because it's not a fear of social situations or a fear of humiliation. So if those are the specific fears, then you have to consider a social anxiety diagnosis. And it's not agoraphobia because it's not related to closed or open spaces. So there are several different types of specific phobias. There's the blood injection injury phobia, the situational phobia like elevators or heights. Um, there's also the natural environment, which is heights, and animal phobias, and then there's others such as choking. It's estimated that the prevalence rate of phobias is between 7 to 11% of our population, but only 3 to 4% of people seek treatment. As I mentioned earlier, a phobia is only significant if it really interferes with your ability to go about your daily life. My fear of snakes, which I don't really think is a phobia, but let's pretend that it was. It's not like I encounter snakes in my daily life. I don't go out of my way to avoid them. They're not in my place of work. They aren't around my children. So it has really little bearing on it. Now, if I was living in an area where that was snake infested, we had snakes in the house, then it was causing me distress on a daily basis. At that point, I might seek intervention. Phobias often emerge during adolescence and usually are coming on prior to the age of 25. They tend to be chronic because we tend to avoid our feared stimuli, but they can fluctuate over the life course. These things tend to rear their heads when we are feeling more stressed, and they're usually assessed by self-report. They did one large study of people who had specific phobias in Sweden with an N of 370, and here are the average ages of onset. So animal phobia, age 7, blood, age 9, dental phobia, age 12, social anxiety disorder, which is not a specific phobia, age 16, and agoraphobia, again, not a specific phobia, age 28. So you can see that the specific phobias, we're seeing an earlier onset as opposed to the other types. And this is kind of when you're doing differential diagnosis, this is something that you want to take into account. So you also have to distinguish phobias from normal development. For example, I have young children, and so I see them fearing different things. Like my 6-year-old right now is pretty afraid of the dark, and he won't get out of bed. He wants to have a nightlight on. He has to call me to help. Like he won't even step foot on the floor because there's like afraid of monsters, things like that. So from birth to 6 months, kids don't like loud noises, lots of physical support, changing positions rapidly. From 7 to 12, you start seeing kind of fear of separation from the parents, strangers, looming objects. They don't like loud noises, will make them cry. Between 1 and 5 years, you start to see fears of strangers, storms, animals, the dark, separation from parents, objects, machines, loud noises, the toilet. It's not a common one. 6 to 12, we start to have fears of ghosts. My son was a little bit afraid of ghosts. He saw one on TV. Bodily injury, disease, burglars, failure, criticism, punishment. And then in the teenage years, 12 to 18, it's really kind of the normal fear of performance in school, peer scrutiny, your fear of, your appearance, and performance anxiety. So, fears of things are quite prevalent. A lot of us have fears that are, bordering on phobias, but may not be quite phobic in nature. Again, largely because they don't interfere with our ability to function in our daily lives. They estimate that about 11% of the population, as I mentioned earlier, has them, but again, only 3 to 4 percent seek treatment. They tend to be more common among women, and they estimate that it's almost double the risk. And generally, they tend to be chronic, as I said, because oftentimes these are things are avoided, and so the only way to treat it is really by exposing yourself to it. So if you don't do that, it's not going to go away on its own. There seems to be some genetic basis for it because 31% of first degree relatives of phobics, or those who had a phobia, had a phobia as well, as compared to only 11% in the general population. They also tended to have the same phobia. So it's really not clear if this is an environmental transmission. So if you see that your mother's afraid of snakes, that you then kind of internalize that fear yourself, or if there's some genetic basis for the fear. There's the case of little Albert. This was by Watson. He induced a fear of he showed how classical conditioning and modeling can reinforce the fear, and so he got him to be afraid of little white bunny rabbits.
In the early part of the 20th century, psychologists John Watson and Rosalie Rayner set out to teach a baby boy called Little Albert to fear white rats using the principle of classical conditioning. This is a film of their work. The film shows several phases of their study. First, as you see here, the investigators demonstrated that prior to conditioning, Little Albert had no fears of any animals, including, of course, white rats. Watson and Rayner then sought to teach Albert to fear white rats through classical conditioning. In the conditioning phase of the study, which was not filmed, the investigators struck a steel bar with a hammer whenever Albert reached for a rat, making a very loud noise that greatly upset and frightened Albert. After 6 such pairings of the loud noise and the rat, it was believed that the boy had been conditioned to fear white rats. That is, Albert was now expected to react fearfully to white rats, whether the rats were paired with loud noises or not. In this next film sequence, we see Albert interacting with a white rat after the conditioning process. The investigators believed that the child's reaction during this trial demonstrated his newly acquired fear of white rats. Finally, the investigators expected that little Albert's conditioned fear of white rats would generalize to stimuli that were similar in key ways to a white rat. In this film segment, they were trying to demonstrate that the child now also reacted fearfully to similar objects, such as a rabbit, a dog, a furry object, and a white mask worn by Watson himself.
That poor child was being tortured there. There's actually an interesting series that was done on the APA Monitor where they actually investigated who little Albert was. And I think he was the son of somebody who worked on the campus, and it turned out that he may have passed away, but they did an investigation into who he was and any long-term consequences. So, very interesting case. Again, that's written up if you wanted to get some additional information on that specific case. But one theory is of the development of specific phobias is Maurer's two-factor model, where you pair this stimulus with aversive unconditional stimulus, which leads to the fear through classical conditioning, and then you, through operant additioning and avoidance, maintain the negative. You maintain it through negative reinforcement. So you have the conditioned stimulus is the dog, and the unconditioned stimulus is the bite, which then results in the classical fear of the dog because the bite has been paired with the dog. Then, by avoiding of the fear through operant conditioning, you then reinforce the fear and maintain it. So there are some problems with the two-factor model. Many people never experience aversive interactions with the phobic object, but develop fears nonetheless. According to classical conditioning, you have to have direct experience, modeling, or verbal instruction. So people with phobias only tend to fear certain types of objects. So there's some evidence for preparedness learning. For example, it might be, we don't fear bunny rabbits, but we do fear snakes, and we know that historically snakes can be poisonous and can kill us. So there might be some, through our evolution, we are taught to fear snakes because they're dangerous to us. Other things such as insects, blood, and heights are also things that we should be fearing, historically, because they can all end our lives. Um, Conditioning models need to be integrated with biological models of fear, according to the critics. Um, and some fears might be biologically programmed, or pre-programmed, as I just mentioned. So there's the kind of the behavioral evolutionary perspective, or the preparedness theory, which was developed by Martin Seligman in 71 to explain why certain associations are learned more readily than others. So phobias related to survival, like snakes, spiders, and heights, are much more common and more easy to induce than other kind of fears. Like it's harder to cause somebody to be afraid of cotton balls than to be afraid of snakes. And so this is, according to Seligman, a result of our evolutionary history. And so we learned to survive in environments where there were dangers by avoiding certain things, and those that were successful had a reproductive advantage. And so that's kind of the theory behind that. And so consequently, we have an innate predisposition to fear these type of objects, and that became kind of an innate adaptive human trait. Um, so it's also been used to explain why we have certain taste aversions and why we learn to hate things that are bitter very quickly, because bitter often meant poisonous, and so it's easier to dislike those kinds of tastes, and we can learn those very quickly through classical conditioning. There's also the cognitive perspective. I like this joke too. I was afraid to fly until I learned I was safer here than in my car, so now I'm afraid to get off the plane. So, as we mentioned earlier, with like similar to other anxiety disorders, there is hyper focus on the fear. So, if somebody is afraid of spiders and there's a spider in the room, they're not going to be able to pay attention to you because they're so hyper focused on that spider. Um, we also overestimate the association between the stimuli and the outcome. So, like, what can a little, daddy long legs in the corner over there do to you? But, somebody with a fear overestimates what can happen. Um, and they usually justify their response because they feel like, because they're feeling anxiety, this then supports that there is something to be afraid about. Like, I feel happy, therefore something is good. I feel scared, therefore something is bad. So, as I mentioned earlier, one of the treatments that we do for phobias is called systematic desensitization, where we teach relaxation techniques, and then we put people in either imaginal, where they imagine situations, but what works better is actually in vivo exposures, where people put themselves in the feared situation at graduating levels. We usually make a hierarchy from 1 to 10, where 1 is kind of things that are less fearful to the person but related to their fear, and 10 is their worst fear. And then you kind of move them up the hierarchy through the sessions to the point where they can tolerate their worst fear with only moderate to mild anxiety. The other technique that I mentioned is flooding, and that's like the fear factor thing that I told you about, where you throw people in, in a tank of snakes or spiders, and you have them stay there until the anxiety dissipates, which could actually doesn't take that long. It's usually after a few minutes. You feel like horribly intensely afraid both before and during, and then that anxiety after a while just wears itself down, and the person is no longer as afraid. The next anxiety disorder that we're going to talk about is panic disorder. So, panic disorder is frequent panic attacks unrelated to specific situations and worry about having more attacks. So, the worry here is key. That's what makes it panic disorder versus panic attack. A panic attack is just the physical attack that you have. It becomes panic disorder when your life is dominated by fears of having another attack, such that, it causes additional anxiety and it limits your ability to function. So panic attack, and this has to kind of happen within minutes. So when people tell you about a panic attack and it goes over several hours, that's not a panic attack. It's usually start to finish about 10 to 15 minutes that a person experiences this. So they have a sudden intense period of fear or discomfort, accompanied with severe physiological symptoms, including sweating, nausea, labored breathing, dizziness, heart palpitations. They may fear losing control or dying, and they feel like this fear of derealization. It's kind of like an out of body experience that they're reporting, and that's going on all around them. And so this kind of happens within a 10-minute period. People who have these often report that they think they're going to die. And even if they've had many of these before, you'll still see people repeatedly going to emergency departments because they feel like they're going to die, even if they've had this sensation and this has happened to them before. These attacks have to come out of the blue, so they're uncued, so it's not in specific situations. Um, and or if they are in response to specific situations, then it's more likely that it's a phobia than a panic disorder. The panic has to come out of the blue, which makes it really hard for the person because there's that anticipatory anxiety, like they never know when it's going to happen. It has to happen for at least 1 month in order to meet diagnostic criteria, with the concern of having more attacks. So even if you don't have a lot of attacks, the fear of having additional attacks has to be, and it has to cause severe, you have to worry about it and cause behavioral changes because of that. So panic disorder usually happens in young adulthood, so you'll see it around the early college years, early adulthood. And 25% of people who have panic disorder are unemployed for more than 5 years because they feel like they can't work because they're so afraid of leaving the house for fear of having a panic attack because they don't know what's going to happen. You'll often see it highly comorbid with agoraphobia because there's a fear of, going out. Other anxieties, depression, bipolar disorder, impulse control disorders, substance abuse disorder to self-medicate, and personality disorders. So agoraphobia is anxiety about situations which could be embarrassing or dangerous to escape if panic occurred. So therefore, they remain oftentimes in the house, and that's why you have the high rates of unemployment. It's usually chronic. Um, Following treatment, which is usually behaviorally based, 30% remit without relapse. So about a third are successful. 30% will realize notable improvements, but the symptoms wax and wane over time. The prognosis is worse when there is agoraphobia present. So if it's got to the point where you can't leave the house, it's harder to treat. It's also harder to get treatment. Fortunately, now with telemedicine, we're hopefully able to change some of that stuff. But in a 22 month follow-up study, 18% recovered, and 43% with who had agoraphobia recovered, and 43% who did not recovered. So you can see the agoraphobia is really kind of an impediment in terms of ability to get better. So there's lots of, if you remember from our genetic slide earlier on, about 48% of twins, there was a 48% concordance rate among monozygotic twins. And so it's thought that there's a large biological or genetic basis to panic disorder. So you'll see that in the locus coeruleus, which is the major source of norepinephrine and triggers the sympathetic nervous system activity, which is our fight or flight response, if you recall. So if we trigger that with an electrical signal or drugs, we can get a panic attack, and especially those who have had a history of panic attack, those the threshold is much lower. And so this is one of the things that once you've had a panic attack, the likelihood that you'll have another one is somewhat increased. So it's estimated that about 30 to 40% of variance in panic disorder is accounted for by genetics via the serotonin transporter gene and the dopamine regulation gene polymorphism. So there is a genetic basis to it, which shows that it's related to genes transmitted through families. So, what accounts for the differences between those who display little or no distress over panic and then the majority who develop panic disorder? Because you can have a panic attack but not develop a panic disorder. Again, the difference is a panic attack is that physiological reaction that can happen, but the disorder is when you have the intense fear of having it, and therefore your life becomes limited because of it. There seems to be some sort of psychological vulnerability among those who develop a panic disorder. So they have an anxious apprehension, so they're hypervigilant, and they're more attuned to their physiological symptoms. We'll also see behavioral factors such as interoceptive conditioning. So you can condition, like there's a conditioning when you have certain sensations in your body that therefore you're having a panic attack, and then one can be precipitated. So it's kind of like a fear of fear. So if you look at this thing, you have a negative life event, which precipitates anxiety, precipitates increased heart rate. You have a panic attack, because as you recall, about 80% who have had panic attacks or panic disorder report that there was a significant life event that preceded it. Then you get the anxious apprehension about those somatic symptoms, and then you start worrying about it, and it becomes panic disorder. So in terms of the etiology, you have the cognitive factors, the fear of bodily changes. So the bodily sensations are interpreted as impending doom. I must, like you feel your heart racing for, let's say, for whatever reason. You then think I must be having a panic attack. The anxiety increases. You get increased physiological arousal. You have a catastrophic misinterpretation, and then the panic attack ensues, and then it becomes a violent cycle. And you'll see that it gets repeated. And so when people experience some of these physiological symptoms, whether they're related to panic attacks or not, they start to experience panic. So this is the cognitive model. You have the internal or external trigger, the perceived threat, the worry and apprehension, the bodily sensations, the catastrophic misinterpretation of the bodily sensations, and then the panic attack ensues, and then you have the cycle that continues. So one of the measures that we use to measure anxiety and panic specifically is the Anxiety Sensitivity Index. So here are some sample questions. This can measure traits that are related to people who will develop panic disorder. There are a number of clinical rating scales and interview scales. You'd want to use the SCID, which is the Structured Clinical Interview Guide for the DSM-5 for diagnostic purposes. But here you can see some items include unusual body sensations scare me. When I notice that my heart is beating rapidly, I worry I might have a heart attack. It scares me when I feel faint. It scares me when I feel shaky. So, I experience all of those on a daily basis with my three kids. However, I know that it's just part of being a parent of three young kids, and I don't have catastrophic misinterpretations of it. And so that's why there are actually two schools of thought when it comes to panic treatment. One is the more cognitive ones where you're targeting some of these cognitions, and the other is the more behavioral one where you actually expose people to the physiological cues, and you teach them how to control them and relax so that they don't precipitate a panic attack. So that's what the interoceptive exposure is where you kind of have somebody, like you spin them around in a chair, get them dizzy, you have them run up and down the stairs so their heart gets racing, and then you talk to them about those symptoms and what panic disorder is and what panic attacks are. You teach them skills such as relaxation to help, and cognitive restructuring to help kind of counteract that catastrophic misinterpretation. And then that hopefully can work to control it. As you saw, about a third of the people who went through these kinds of treatments eventually were symptom free from their panic. So, panic control therapy, which was developed by Barlow and Kraske, is exposure to somatic sensations associated with panic in a safe setting. So, you usually do it in the office of the psychologist or psychiatrist. So, you get them to have increased heart rate, you have them breathe in a paper bag, you spin them around in the chair to make them dizzy. You then talk them through it. You give them coping strategies to control the symptoms like relaxation and deep breathing. And then they learn to stop seeing internal sensations as signals of loss of control and see them instead of harmless sensations that they can control with techniques like the relaxation and the deep breathing. You can also treat it with medications. Again, I I would advocate, unless it becomes incredibly intense, not to do it because it teaches people that they cannot control it themselves, that the medication is controlling it. So once they go off the meds, the panic resumes at usually the same level. But you can also then combine treatments with medications with the goal of inevitably weaning people off the medications, because whenever they feel that they do not have control over the situation is when you see kind of the relapse and the uptake of the symptoms once again. Agoraphobia. So, agoraphobia is the presence is anxiety about being in places or situations in which escape might be difficult or help might not be available, or embarrassment might occur in the event of having a panic attack or other incapacitating symptoms like falling. So you can see this in the case of being outside, being in a crowd, standing in a line, or traveling on buses or trains. And so situations that have potential for causing attacks or where incapacitating symptoms may occur are avoided or endured with great anxiety. So you'll see these individuals will go out of their way not to be in crowded situations. If they leave their home, they'll only do so in off hours. They won't go to concerts or parties or things like that. And there's an active avoidance and or distress which has to last for at least 6 months in order to be diagnosed. So you have to have a marked fear or anxiety about two or more of the following five situations: using public transportation, being in open spaces, being in enclosed spaces, standing in a line or being in a crowd, or being outside the home alone. So if they only fear one of these situations, then it might be a specific situational phobia, as we described earlier, but it has to be at least in two situations in order for it to be described as agoraphobia. It's one of the most prevalent of all the phobias and occurs in a frequency of 6 out of 1,000 cases, and about 50 to 80% of people with agoraphobia seek assistance. One of the issues that kind of comes about is that the problem is that if you cannot leave the house or you fear, it then impacts your ability to get treatment. Um, it suddenly begins between the ages of 18 and 31, so kind of again in young adulthood. About 13% of the cases do happen after the age of 40, but it's least common among those who are 65 and above. The lifetime prevalence is somewhere between 1.5 to 3.5% of the population. In any given year, you'll see 1 to 2% with diagnoses. You see highly comorbid with panic disorder, about 50%, and you also see high levels of substance use to self-medicate again, and major depression. As you can imagine, if you're afraid of these different situations, it would be very hard for you then to to be happy. I mean, if you can't leave your house and you can't work effectively, that can result in depression. We see a high degree of heritability, such that first degree biological relatives have 4 to 7 times a greater chance of developing agoraphobia than second or third degree relatives. It's often persistent and chronic without treatment. Again, if you think of Mauer's two-factor theory, you're reinforcing the fear by not going outside. So therefore, it's important to one of the treatments actually avoids, it includes exposure to these things. And you see a tendency to develop a dependency on special people. So some people can go in public areas if they are with a certain person. It makes it easier. So that doesn't, even if they can go in public with somebody else, it's only if they're by themselves that it becomes an agoraphobia. It seems it's different, but yet it's the same. There's some fear hypothesis. There's the fear of the fear hypothesis, where you have expectations about catastrophic consequences, like having a public panic attack, falling, or incontinence. And then because you have that fear and you avoid it, that fear gets reinforced even if it becomes irrational. There's this fear of losing control in public and the fear of embarrassment. There may have been a panic attack or an embarrassing situation that predisposed it. So, just like with panic disorders, CBT, such as panic controlled treatment, can also be effective for agoraphobia. And it works better if you have situations in which the person that's kind of helping the individual facilitate these things is no longer helping facilitate that to avoid the avoidance. So in terms of you can also medicate again with benzos, SSRIs, antidepressants. We do see again effectiveness, but the effectiveness diminishes once the medication is continued. Sorry, I meant discontinued. Now let's talk a little bit about social anxiety disorder. So, social anxiety disorder is something we probably all have to a certain extent. It's not a disorder. We probably all have some social anxiety. And if you don't, hooray for you. But it's the fear of social or performance situations like going out to parties and mingling, speaking in public, eating in public. So as I said, this is where we kind of talk about the categorical versus dimensional diagnosis. So all of us probably feel somewhat uncomfortable in speaking in public. Again, if you do not at all and you can speak in front of, hundreds and thousands of people, power to you. But many of us, have kind of learned to either tolerate it or overcome it with, practice. Social situations. Again, there are some people who love those things. Generally, it's not my favorite cup of tea. I hate walking into a party, especially when I don't know anybody and having to socialize. I'd rather just much stay by myself. Eating in public, not so much of an issue for me, but some people fear eating in public. So again, like other things, this is kind of like a spectrum. And so you have people kind of on the bottom with minimal or average shyness. We all have some shyness or no social anxiety. Then you have moderate and high. And they kind of categorize it like such that you have social phobia versus generalized social phobia. And then at the higher end of the spectrum, when somebody is completely avoidant, then you have avoidant personality disorder, such that you're avoiding all social contact in general. So in terms of the diagnostic criteria, it's a marked and persistent fear for 6 months or more in one or more social situations in which the individual is exposed to possible scrutiny by others. So, having a conversation, meeting unfamiliar people, being observed, performing in front of others, because fears of the anxiety symptoms will show and a negative evaluation will ensue. So, here's the key thing. The thing with social anxiety disorder is that people really, the ultimate fear is the negative evaluation of others, from others, that they fear that people will evaluate them negatively based upon their poor performance. So, exposure to these feared situations is often associated with extreme anxiety. The person recognizes that the fear is excessive or unreasonable, and they're in these situations are endured with intense anxiety or avoided. So you'll see people are dropping courses or avoiding courses altogether, will have public speaking components, and they just avoid going to parties, etc. It's estimated that the prevalence rate in the US is somewhere between 2 and 12, which is kind of a big, prevalence, but it depends on the threshold of the disability, like how much it's impacting. So, if you can still get your degree by not taking any courses with public speaking, has that really impaired your life that much? But if, for example, you didn't finish your degree because it would require you doing public speaking, then maybe that is, diagnosable in that case. It's unclear whether gender makes a difference. We do see more females than males, but we do see males seeking treatment more often than females because, if you have to, for example, speak in the workplace, men may feel more motivated, whereas women might choose positions where they don't have to speak as much. That's like a social thing that social way of socialization in our society. We'll probably see changes in that as our society continues to change and gender norms continue to change. You usually see the onset at the age of kind of mid-teens, around 15, and it usually has a chronic and unremitting course, especially if untreated. It's usually associated with other anxiety disorders, depression again, because it limits your ability to function in society. People often self-medicate, so you see substance abuse and some other somatoform disorders, so where you have physical symptoms and things like that. You'll often see a higher concordance rate with avoidant personality disorder, so then it's unclear whether it's really social anxiety or avoidant personality disorder. Simple phobias, agoraphobia, alcohol abuse, and depression are concordant, and those are the percentages beside them. Um, in terms of its effects, it causes impairment and disability because you'll see problems in the work and social functioning of individuals with social anxiety disorder. Some may be unable to work, attend school, or socialize, especially when they're kind of at the high end of that spectrum. Again, we see a lot of um, social anxiety when people who have substance abuse, specifically alcoholism, are undergoing detox, that it comes out that there's like a social anxiety disorder that they were medicating with alcohol. There is the hypothesis that temperament, again, is related. We saw that with some of the other anxiety disorders. So behaviorally inhibited children at 4 months remained inhibited at 4.5 years. And then it predicted the anxiety symptoms at age 7 and 12. So Kagan proposed that these differences are innate and there are different brain structures and biochemistries. And he found that inhibited children have higher resting heart rates, greater increase in pupil size in response to unfamiliar stimuli, and higher levels of cortisol, which is released with stress, as we talked about earlier in the fight or flight response. It does run in families, so does behavioral inhibition. Um, but there's only a slight evidence for genetic contribution to social anxiety disorder. So it could be learned through anxious modeling of parents. So, if we view our parents that are handling situations in a certain way, that's how we may learn to handle them as well. Um, Again, Mauer's two-factor theory could come into place, and so people have avoidance or safety behaviors or things that they do to cope, like like wearing their special underwear. Cognitive factors are come into play, and you'll see that therapy for social anxiety disorder involves kind of cognitive restructuring as well as behavioral exposure. We'll have very strong negative self-evaluation, so people often think that they're going to be much worse than they actually are. And then, um, people want to make a good impression, but they expect that they're not going to make good impressions. And so uh, then there's that fear of negative appraisal, that they're going to be an embarrassment. There's also the fear that they're socially inadequate. And again, they rate their performance as more negative than other people do. There we go. There's also the integrated model of what causes social anxiety disorder. So, according to the integrated model, there's the biological learned predisposition plus performance-based anxieties. You have a physiological hyperarousal, negative cognitions prior to and during and after the event. You try to escape and avoid it at all possible. And then because you're so anxious, this then kind of, if you're feeling so anxious, you then do actually perform worse, and therefore kind of the vicious cycle occurs. For some people, there is a skills deficit such that they do have problems, and you have to evaluate that as a therapist to make sure, like maybe they don't have social skills, or maybe they are incapable of doing a good presentation, and so you have to remediate those before you can actually then target the behaviors. But in some cases the skills are already there, but it's really just the fear that's inhibiting the performance. So in terms of treatment, the most common treatment for social anxiety disorder is CBT. So you have exposure. You have role playing in small group situations. You might actually construct artificial groups. So if you're doing this individually, you might have people, you might make them give a presentation in front of a group that knows, what's going on. You also then have cognitive restructuring about the negative appraisal of other people, and you have them videotape themselves and rate themselves. And so here's one of the cases where cognitive restructuring actually does enhance the treatment effectiveness. For the social phobia, but not for specific phobias. You can also then medicate, but again, medication is not getting at the root of the problem, but it does decrease